All right, welcome everyone. Welcome Women's Advantage family. We are here to talk about persistent pelvic pain conditions in the pelvis, both in the female and the male population. And we are glad you are joining us tonight. I want to introduce first our staff member, Dr. Quozette Valera, and she is our clinic manager down at our Long Beach location. Works a little bit out of our Torrance location, and she is going to be running the interview today. And I will let her introduce the two powerhouse physicians we have with us tonight who are talking about pelvic pain and the medical perspective of that. But first, Q is going to give us some big, broad overview pictures of especially the pelvic floor and how that can be involved in persistent pain. So if you have questions during the chat, go ahead and put them down into the chat box that you'll see in the middle bottom of your screen. And we will probably hold those questions till the very end, unless there's something really burning that I pop in and add. So we will hand it off to Q.
Hi, everyone. Thanks for joining us on a very lovely Wednesday. That looks pretty gloomy up here. I don't know how it is in San Diego. We are
Very
talking
sunny.
sunny. Jealous. So we have Drs. Jocelyn Craig, who is a local urogynecologist in Long Beach. She's probably one of our top referrers for sure. And Dr. Irwin Goldstein in San Diego, who is a sexual medicine doctor, who is a frequent host and lecturer at the PROPHYSM or pelvic floor and sexual medicine meetings that we used to have pre-COVID, which Jenny is a steering committee member of. So we are happy to have them. So Dr. Craig, would you like to introduce yourself and a little bit of background on your practice?
Sure. I am a urogynecologist and I've been in private practice in Long Beach since 2010, I think. Yeah. I did my fellowship at UC Irvine. I was one of their very first fellows through there. And it's a 3-year fellowship divided between aspects of colorectal, gynecology, urology, and research. My specific research, and continues to be a focus area of interest for me, is in fecal incontinence. So I did some early research studies in stem cell regeneration of the anal sphincter. And I would say I have a fairly healthy balance of patients in my practice. I see quite a few for fecal issues, but also prolapse, overactive bladder, and also pain. So I think it's a full spectrum. It's a healthy balance of medical and surgical patients. I share an office with 5 OBGYN, so there's some natural overflow there, but I also see patients from physicians in the community. I run a pelvic floor program at the Long Beach Memorial, which is really virtual, but we're working on an actual physical center. It's in the works, but COVID has put the brakes on pretty much everything, right? But really at this point, trying to have a network of working together with specialists in pelvic floor.
Awesome. Thank you for joining us. Dr. Goldstein, want to give us the gist of what you're doing down in San Diego?
So thank you to Jenny. Thank you to Q. I've never called you Q before. Craig. I'm a board certified urologist and have never a single day done urology. So when I was a urologist, we were placing penile implants in a large number of penile implants per year. And I got completely fascinated. I'm an electrical biomedical engineer before I became a urologist. And the idea of studying the subspecialty of urology called sexual medicine was really exciting. I've written many grants, 25 years of funding by the NIH, and we have lots and lots of publications of the basic science. And we were involved in Viagra and all the other sort of therapies. And then when Viagra came out in 1998, I was the first author of the New England Journal paper, which was widely read, one could argue, all the data of Viagra in the New England Journal. So the first author gets the phone calls from all the people asking questions. So you can only imagine how many phone calls we got in our office with that thing. And to my amazement and surprise, even today in 2021, in 1998, probably 90% of the people that called us were women. And I was astounded at the concept that we in urology had embraced sexual medicine for men, but there was no like other alternative specialty in medicine that embraced women's sexual health issues. And we thought that was completely unfair and unreasonable. And we started ISWISH at that time, the International Society to Study Women's Sexual Health, started in 1998. And it's grown with, more than 1,000 members, and we're really growing. And our practice became equal male and female. So we do the study of sexual medicine, the specialty in medicine that does the study, diagnosis, and treatment of men and women with sexual health problems. Well, the thing is, pain, pelvic pain, is a huge component of both men and female, male and female sexual problems. So I've teamed up with a bunch of specialists to address this, and when we get a chance, we'll sort of go over our new findings.
Thank you for being here. So before we dive into all of the wisdom that we'll get from our experts, we're going to start with a general overview of all of the pelvic floor muscles, just to give an understanding of what are the common drivers of pelvic pain, because pelvic pain is rarely the result of just one structure or one tissue being problematic. It's usually the result of a combination of factors. So the pelvic floor obviously is at the base of the pelvis. And if you are a patient with us, you are very familiar with that. But within the pelvis, we have several organs. So whether it's the uterus and the ovaries or the prostate, these organs have to function with the pelvic floor and vice versa to maintain things like continence, stability, to help with circulation. And when those things go awry, then we can see some symptoms of pain. And so when it comes to pain, we always start with a conversation about the nervous system, primarily because every muscle in the body is regulated by or governed by the nervous system. So I describe the nervous system as the freeway that carries information from the tissues in the body all the way up to the brain, so that the brain can decide what to do with this information and send hopefully an appropriate response. But what happens when that system gets overwhelmed with lots of information, especially negative information like pain, the brain gets a little bit overwhelmed and the response might not be what we want it to be. And one of the components of that response in response to pain is muscle tension. So that's where the pelvic floor muscles tend to become overactive and very rigid, less flexible, and that can obviously contribute to things like sexual dysfunction, particularly with penetrative intercourse for most of our female patients. So we definitely look at all those factors when we address pain, but we can't do it alone as physical therapists, because all of the factors within pelvic pain have to be addressed by a team of professionals who are very well versed in that part of the body. So when we discuss pelvic pain tonight, we're going to first start with the female conditions and some things that Dr. Craig sees in her practice that are very commonly referred to therapy for. And Dr. Goldstein will talk about some male conditions as well. So we can start with Dr. Craig. So let's start with, we obviously have tons of conversations about the things that we see clinically, and pelvic pain obviously has many layers to it. Why don't we start with a couple of diagnostic things or criteria that you do within your office to help figure out where the source of pain is coming from? Because everything is kind of related, right? Whether it's bladder pain, vaginal pain, vulvar pain, those kinds of things. So let's start with that.
So when patients come in initially for a new patient, I really just sit and take their story, and I'm looking at their medical history, their surgical history, really listening to what they bring up first as far as what's bothering them, right? But as you said, there's sort of a freeway, right? The pelvic floor, I think it's the intersection of so many things. And I feel like my job is almost like this, what do you call it? The person who's directing traffic in the freeway, right? Because often the patients come in with one singular thing that's causing pain for them. but they're not aware that the fact that they've had hip surgery, or the fact that they're a ballet dancer, or the fact that they sit for 7 hours a day teaching piano, are all factors, right, in their symptoms. And so really initially I'm listening to all of that, and trying to create sort of a picture of spatterings of, okay, what do I need to look at? What are the extra things that I need to ask? But I really try not to direct them, because if you wait, people are going to tell you their story, right? But they don't know some of the other aspects that might fit into it. So always a physical exam. Pretty much I always do a post-void residual, because you can often be surprised there. But the pelvic exam is not just, it's not just, often women think they're getting a pap smear when they come in. And that's not what I'm doing. I'm really carefully looking on the outside, the genitalia. I'm looking for nerve responses, tissue changes. I'm really individually feeling the muscles. And I think that was the beauty of our fellowship at UC Irvine, was that we had pelvic floor physical therapists with us. And so we really did learn along the way really how to examine patients. It depends on what the story is that I'm getting. Not everybody needs a big diagnostic workup.
Right.
Some people do need a cystoscopy, looking in the bladder with the camera. Some people do need urodynamics. Some people do need imaging. But I also want to hear from the patient the level of bother of what's going on, right? And since as a urogynecologist, often I'm getting referrals of patients who have seen many people before me. And often if they're pain patients, they're frustrated. So I'm really also making a list in my mind, what has been tried, what worked, what didn't, what can I add to this that's not just going to lead to more frustration.
Right. Yeah. And I'm assuming that when you attempt to do some of those exams, that's when we discover that the pelvic floor typically needs a little bit of attention as well.
Exactly.
So how would you counsel somebody who's experiencing, say, interstitial cystitis or painful bladder syndrome, who may have that muscular component, and how to distinguish and figure out what's driving the pain and ways to manage it, whether that's through medical management with pharmacology or the physical therapy, or both, right? Because sometimes it's both.
Well, I think for me personally, I'm always trying to get patients off of oral pain medication and looking at local, either injected or vaginal medication. But really, that's not my first go-to. With patients with interstitial cystitis, a lot of times they've already seen multiple people, right? And I'm sorry, I keep looking at your picture on the screen, but I realize I have to look at the camera. So many patients have already heard about dietary triggers. Many people have tried, you go on the internet, there's 100 different ways to treat interstitial cystitis, right? But a lot of times the pelvic floor itself has not been addressed. And it's, what is it? The statistics are like 80 to 90% of patients with interstitial cystitis have pelvic floor involvement. So sometimes it is, I have to be a little bit of a cheerleader to say, hey, try something different, right? Try, and then it also helps when you can examine the patient and say, where's your pain? And they're like, oh, that's it. And you say to them, this is actually pelvic floor, right? And this is indirectly affecting your bladder. So when I send patients for pelvic floor physical therapy that are IC, or really a lot of these, I try to send them without any medication on board first, so that you, the therapist, can see where they are at their baseline, right? And also, I don't want to assume that everyone needs some kind of medication. So if pain is an issue as far as being able to tolerate physical therapy, use compounded vaginal medications or medications that could be placed rectally for pain. And I regularly do blocks if necessary, or trigger points as well, which can be done in conjunction with physical therapy to reduce pain.
Awesome. And when you mentioned that you always prefer to get the patients off of the oral and prefer the localized, can you explain kind of the physiology and the reasoning behind why it's probably better to go with the localized medication versus oral?
Yeah, anything you're taking orally is got to go through the bypass of the GI system too, right? And we are all at this point worried about dependency as well. So whenever possible, we prefer to target the specific area of the body or organ specifically.
Yeah, I know a lot of patients are a little bit, they get the prescription for their compounded suppository or vaginal or topical even, and they're just like, I don't know, I don't know if I like that, and tell them give it a try. It was made for you. It was prescribed for you specifically, but that is definitely a hurdle that we sometimes approach. And yeah, can you speak to some of the effects and the reasoning for some of those medications?
Yeah, so I mean, with compounded medication, the idea is that it can be absorbed through the mucosa as well, surfaces as well. And so the goal would be to target that area and give it the biggest pain relief, but directly to it. As far as pudendal blocks, I think that is often something I have to talk patients into. They think, oh my gosh, an injection, in the pelvic floor. I am old enough that as an OBGYN resident, I did these routinely when we had patients who were too far into their labor and couldn't have an epidural, right? Yes. So that's what we used to do when women were ready to deliver. I mean, we didn't give people spinals as often as they do now. So we did saddle blocks. Yeah. So it's the same way as I learned in residency, honestly. But the idea is to give some local pain relief and hopefully a steroid and shut down some of the inflammation, but pain associated, so that it allows the therapist to get deeper into the tissue and hopefully push the patient further in their therapy. And often I have to talk patients into that because that sounds really scary to have a needle in that area. So that's shutting it down temporarily. Pudendal blocks are not intended to last long term. Some patients get longer relief out of them than a couple of hours. I also use some vaginal Botox on a fairly regular basis. And that is, Botox lasts longer in the body and actually is going to last several months. So again, we'd want to just use it in the localized area and hopefully shut down some of the pain pathways and allow them to accelerate in their treatment. Yeah.
This is, I think when you mentioned you're the traffic control person on the nervous system freeway, I imagine those cop cars that all of a sudden start going, making that S pattern to slow everybody down. That's what I think of when I think of those medical management options for patients. And I tell them too, your nervous system needs a break. This is temporary, but it'll give us a window to work within a less painful situation where you're not going to be fighting the therapy or fighting these exercises and treatments. So I love when patients come back after, particularly right after they get one of those injections. The other day, I think of the patient that saw you, they were coming in for the bladder, but they needed a tailbone manipulation. And we were able to do that the same day. So that was really nice. And she got a lot of relief from that too. So
yeah.
Speaking of pudendal neuralgia, I think there's a lot online that scares people about what it is and how. I've had patients say, I Googled it and there's these forums where people are almost suicidal because the pain is so bad. And I think one of the common symptoms is the burning with sitting. And can you speak to kind of differentiating for a patient how to tell whether that's nerve versus maybe some yeast issues or some vaginal issues with the vulva and those, the balance there? So.
Yeah, I think Inuit populations have like, I don't know, 100 words for snow, right? And we seem to have all these different ways of describing pain, right? Burning pain, stabbing pain, itching pain, things like that. And so, again, I'm trying to filter out when patients come to me what they've been told and what they feel. And I will frequently see patients that have been treated over and over for yeast infections or bacterial infections that aren't there. And the idea that burning pain might actually be nerve related is often something that's new to them. And you have to sort of like remind them that Dr. Google didn't go to medical school, right? Again, the traffic controller. Dr. Google only knows the one search engine that you put in, right? But we as physicians are going, yes, but I know that it can be related to all these other things as well. So of course, I'm looking to see if there's any, evidence of infection. I'm looking to see if there is any prior cultures or anything that shows prior infections, but the symptoms often that we use the language that we're familiar with, right? And so sometimes I'm saying to them, I understand it's burning pain, but it's actually not a yeast infection. That is also how nerve pain feels too. There's also a very, a lot of people are disconnected from their pelvic floor. A lot of people have trouble describing what's going on because they've never thought about it, right? So they're just using the language that they have. And sometimes I have to help them understand that it's the correct language, but the reason for it is different, right? So nerve pain can feel like a yeast infection. Patients with pudendal neuralgia will come and say, there's this burning pain, there's this itching pain around my anus. I feel like there's a tampon stuck halfway in. I feel like there's a bicycle seat stuck up in my vagina or my rectum. And we're all familiar with that description. And it's very descriptive, but it's often nerve related.
Right. And I found that once the intensity at least calms down a little bit and we're able to get a little bit deeper into the deep pelvic floor layers, a lot of patients start to realize that there's a component of sensitivity actually in the vaginal walls themselves. Because at that point they're connected to, okay, you're pushing on that muscle and it used to hurt and now it doesn't. But what is that other sensation I'm feeling? So can you speak to kind of the vaginal pain and what the roles are of hormones and those types of common changes throughout the lifespan?
Well, I mean,
when it comes to pain, obviously.
when it comes to what?
When it comes to pain and how it affects pain.
As far as using hormones, you mean, or?
Yeah, hormones are just those, I think of the buzzword is the hormones, right? Everybody wants to talk about, is estrogen good or bad? Is it bioidentical? But the role of that within somebody who's experiencing vaginal pain and who's a good candidate for that. How do you distinguish that in your practice?
Yeah. So, I mean, we can't code for it, but there is something called genitourinary syndrome of menopause, and it presents with all those symptoms that feel like a UTI, that feel like burning, yeast infection. And a lot of women remember when we went through the Women's Health Initiative and everybody was taking off estrogen, but they don't understand or haven't been told, the difference between vaginal estrogen versus oral, right? Mm-hmm. And so again, it's listening to who they are as a person. What is their personal history? What are the risks in giving them some low dose vaginal estrogen, which are usually pretty low. Okay. And so it's about education and explaining that the absorption isn't as great, but that the local effect is tremendous, right? And so even patients who have a cancer diagnosis, a breast cancer diagnosis, they're not created equal either, right? So some patients truly cannot use vaginal estrogen, but a lot can. And so I do run through how is it different from oral estrogen versus vaginal? What are the benefits? Improved, blood flow. We know that vaginal estrogen helps reduce bladder infections. We know that it's going to make the tissue in the vagina tremendously healthier. And the word thick always sounds bad, but it makes it hardier in a sense, right? And so I try to get women on it whenever it's appropriate. And a lot of times it is at low dose. So it can be beneficial to pain in aspects of, just that symptoms of sort of irritation, urgency frequency, right? But also pain with intercourse, okay? And dryness.
Yeah. Since your background is mostly the urology, I love the bladder. It's one of my favorite topics, and I don't know why, but it's one of my favorite topics, particularly the frequency. And I don't think a lot of people connect the dots between their habits throughout the day regarding their bladder and bowel function. And a lot of people don't recognize that their normal, which is what they're used to doing for their entire existence, is not necessarily ideal, particularly with regularity for the bowel. So a lot of people, we say constipated until proven otherwise, because I don't think people really define that in their heads, because they think what they're doing is what everyone's doing. Versus the bladder, right? We know the norms. We know ideally you'd go every 2 to 4 hours. This is how much water you should drink depending on your activity and your size. So can you speak to the kind of under the radar symptoms or habits that do affect pelvic pain that people don't really think of?
Yeah, so a lot of little girls were taught that before you leave the house, you have to go to the bathroom, right? And not to use public restrooms. And you would be surprised how many women will not sit down on a toilet seat even, right? That's not their own. And also there's this fear of, what if I'm somewhere where I can't use the bathroom? There's also this sort of clenching of the pelvic floor too. So, I routinely use a voiding diary, a bladder diary, whenever I can, because it really is some education. It helps me know how well they can follow some instructions, right? It helps me see, without any judgment for them or, anybody, what are they doing in a normal day, and it can be really eye-opening for people. And I think it's the beginning of patients beginning to connect their habits with what they're feeling. And I think that is a beautiful point when a patient comes back and they begin to put it all together, and they're finally beginning to be aware of their pelvic floor, and they go, oh, and I say to them, the bladder is a muscle, and if it's healthy, if it's a normal muscle, okay, you can train it to hold more or hold less. But if you are repeatedly responding to that first trigger, right, that first urge, you're just teaching it to hold less and less. It's a dynamic muscle. It should stretch and empty, but we can teach it to hold less and less. So, I forgot what my basis was, but that can be described for patients as pain when they don't ever let the bladder get full, or when they maybe have gotten fuller than they normally would, and then they can't empty, and they describe that as pain. So that takes a while to change. That's a habit, right? And so the voiding diary helps us look at that and say, how can we help you slowly, just like a personal trainer, change some of your habits and make your bladder healthier too? I think overactive bladder is an interesting area when it comes to pelvic pain, because patients don't necessarily come to you saying, I have pain. They're saying, I have pressure. I have this constant urgency feeling. I'm thinking right now I have a patient who is, I guess, a professional ballerina, right? And came to me with urgency frequency. But when you think about it, just contracting her pelvic floor muscles the same way all the time, right? And some of those incredible physical leaps, but not actually learning how to lengthen and stretch those muscles.
Right.
Yeah. So she was getting more and more symptoms of urgency frequency, but the issue was learning to be in touch with those muscles and learn how to lengthen and stretch them also.
Yeah, I call those reverse Kegels, because everybody knows what a Kegel is, but nobody knows how to let the Kegel go. So.
Exactly. Yeah. And everybody's thinking about strengthening. And I just use a simple example. I was like, just imagine that I'm doing, pull-ups on a monkey bars, and I've done 5, and I couldn't do 5, right? But I'm already shaking, right? And if you say to me, do 6, there's nowhere for me to go, right? So the same thing with the pelvic floor. I could tell you all day to Kegel, but if you're already so tight, it's not going to happen.
Yeah. Right. And a lot of the times I think the people who are in the most need of the internal treatment or the nerve blocks, we just can't get there for a while. So it does take, like you said, with a personal trainer, it takes a little bit of time to get the wheel turning and see some positive effects and to really stick with it. So I think the last question before we switch gears and talk about the men is, can you speak a little bit about Botox for the bladder while we're on that topic, and who is appropriate for that, and who you might think would benefit, and where does that fit in the scheme of, should we try therapy first, or should we try it with therapy or after? How does that process
Yeah, so for Botox for the bladder is indicated for overactive bladder and urgent incontinence that hasn't been treated with other measures such as conservative treatment or medication. Botox for the bladder is injected directly into the detrusor muscle itself. And in bladder muscle, it lasts for 6 to 12 months. It's not really, I don't use it for pain per se. I do use vaginal Botox for patients who have pain or muscle spasm that's not relieved. But vaginal Botox is approved by the FDA and is covered by insurance and can be a great way to help people that haven't responded to other measures for overactive bladder and urgent incontinence. There's a risk of urinary retention, but it's very, it's fairly low. Honestly, knock on wood, I haven't had to treat anybody with that. At the dose that we're injecting into the bladder, it's a low risk. There's a risk that they have some increased bladder infections as well. That's something that we tell them. I think the biggest disappointment for patients is it wears off and they have to have it repeated, right? Vaginal Botox lasts about 3 months as well. And that to me has been, for a lot of people, miraculous. That unfortunately is not covered by insurance regularly. Unfortunately, they don't believe in the vagina, but it can be a great way to help somebody long-term who has not responded to therapy alone, to compounded medications, things like that. Yeah.
Thank you so much. I think we're going to switch gears for now and we'll come back, circle back if anything pops into your head that you'd like to share, any anecdotal pearls of wisdom that come up. Thank you so much for all of that information. I would love to come see you do a nerve block because when I tell patients, and I know you'll text me and say, I think she'd benefit, maybe talk to you about it.
Come on over.
All right. So Dr. Goldstein, you're up. Have you been itching in your seat to jump in and talk?
He's been so quiet.
I know.
I love learning.
So is there anything you want to start off with based on what we just talked about? So bladder, prostate, anything that you have a preference on? I know you have some visuals to share.
Big slide guy. So you sadly have given me privileges to show slides. So what I would like to do here is show you, I think, the contemporary way to think of pelvic pain, men and women. And I just want to share with you some of these slides. Can you see all this? Is it my pointer and all that? All right. So I'm a big friend of Barry Kamazarek. I don't know if anybody knows him. He's a neurophysiologist at Rutgers University, and he's brilliant. And he does fMRIs. Now, Jenny talked about fMRIs of people having intercourse, and this is not that, Jenny. I just want you to know that. So you have a region of your brain up in your noggin here that is called the somatosensory cortex. So anything that you feel is processed in the somatosensory cortex. So if you touch your tongue, if you touch your nose, if you touch your ear, there's a region in the brain for that. So the pelvis, okay, is always seen in the paracentral lobule. So if this is the tongue and if this is the nose and these are the hands, in this region here is the paracentral lobule. So this is an fMRI of that somatosensory cortex where people process sensation. So this individual is lying in the fMRI unit, and the instructions were take your left hand and right hand and touch your clitoris. Happened to be a woman in the room. So this is the region that the hand is used on left side, right side, and this little olive-like structure is the lighting up of the clitoris. Okay, and that is in the paracentral lobule. So it's in the middle of the event. Now, in a woman with pain or a man with pain, chronic pelvic pain, for which they can't control, for which they have devastation, bother, distress, suicidality. I mean, they're just devastated by this thing. If you did an fMRI while they're having their symptoms, in the paracentral lobule, you get this grapefruit thing versus this olive thing, and they're not volunteering this at all. It's a highly intense, spontaneous message to the brain. So you spoke of the highway. Jocelyn also spoke of the highway. This is the highway from the pelvis to the brain. This is the final stop. Anything sacral, S1, S2, S3, S4, is represented in the paracentral lobule. Okay, so your anus, your bladder, you mentioned bladder, the genitals, the scrotum, the perineum, all that stuff is paracentral lobule. So it speaks of, if you see this and understand this, then the next question is, well, where the freak is this goddamn trigger coming from, so that we can stop this unwanted activity and people can have a life again. So,
Mhm.
the whole point is, if that's the basis for all pelvic pain, and when I say pain, I use the word dysesthesia. We don't use the word pain that much anymore. We call these genitopelvic dysesthesias. So the contemporary term is that. So dysfunctional feeling is a dysesthesia. Jocelyn mentioned burning and itching and pain, and we see arousal as an unwanted dysesthesia. People are having arousal feelings when they don't want that, and it's not a sexual event. So here's your highway, okay? It's either in the genital area, for which we could do cystoscopies, vulvoscopies, fingers here, fingers there, whatever. Then the pelvis perineum, for which we engage you guys as PT to do all our things, the pudendal nerve, anything. Jocelyn talked about pudendal nerve blocks. So this is region 1 is the genital area, region 2 is the pelvis perineum. And then there's this bizarre region called the cauda equina, and we'll spend a few seconds on that, where you can't touch it, you can't feel it, it's not anywhere for you to play with, but it is in that highway, and it is a huge player. I mean, now in San Diego, I work with a spine surgeon. We've done 100 surgeries, even in PTs who have had this unwanted arousal situation, for which we have a very high cure rate, because it's so logical that if you have a trigger causing an irritation of a nerve root in the sacrospinal region that transfers information to the paracentral lobule, if you can undo that radiculopathy, then you cure their pelvic pain problem. And then there's, of course, finally get to the spine. We had a guy today who fractured his neck and had a cervical issue with his issue. And then, of course, the brain. So we think of all of this differently. And I think this is the way of the future. And let's say, for example, Jocelyn was taking a history. She mentioned over and over again, she speaks to the people, she talks to them. It's all about the history. So if a man or a woman said, I have bladder issues, I have rectal issues, my vagina hurts, my clitoris hurts, this whole region is just making me crazy. And then that person said, you know, I also get weird feelings in my buttock area. And you know what? I get this weird pain going down my leg into my foot, okay? Well, that can't be the genital, and that can't be the pelvis perineum. That's cauda equina. So that person, just by giving that history, has sort of said, wow, I have sciatic nerve involvement, I have pudendal nerve involvement, and where those come together, that is not in the pelvis or perineum and not in the region 1. That's only region 3. So that's where we sort of do a lot of work on. I don't know what other slides I can show you because I'm having so much fun doing this.
Well, I was
ask me
gonna
some
say,
questions, I guess, right? So,
You
you know, these are the pelvis, these are the region 1 stuff that causes your pelvic pain. This is all, you know, the urethra, the vestibule, the keratin pearls in the clitoris, the candidiasis, you know, lichen planus, lichen sclerosis, or herpes. These are all things that can do that. But, you know, the reality is it could also be, and we do anesthesia testing. We do a lot of anesthesia testing. We use a cream called benzocaine lidocaine tetracaine, and we use the acronym BLT. And we just numb things. And we say, okay, Mary or John, whoever's in my room, and you have this pain in the tip of your penis, or you have this unbelievable clitoridynia situation, or you can't have, you have a vestibulodynia, or you have IC, or whatever you have, I'll take a BLT and I'll numb the urethral meatus. I'll numb the heart's line to the hymen called the vestibule, or we'll numb out the clitoris. And we say, well, what the hell happened to your symptom? I mean, they have to have symptoms coming in, but virtually everybody does. But if we can knock down their symptoms, well, it's hard to argue that what we knock down is not a contributor, at least a contributor, to that intense information in the paracentral lobule. Okay, it's just a logical sort of thing. We have developed some tests to help us understand this, and this is region 2 called your favorite pelvic floor world. I mean, it's like critical and needed, and region 2 is a huge issue. And we have tests where we do like pudendal nerves or neuromodulation of the nerves, or injections in Alcock's canal or transvaginal injections or transvestibular. We do vascular testing. And here's region 3. You know, this is a Tarlov cyst. This is a nerve root, S3. Can you imagine this crazy cyst which binds and adheres to the nerve root, and that's causing firing of the nerve root all the time? The S3 is bladder, it's anus, it's rectum. I mean, it's all that stuff. So that's a genuine reason for which you can't touch, feel, test easily. But what we'll do is we'll get MRIs. So Jocelyn mentioned imaging. MRIs are a staple in our world, and we read hundreds and hundreds of MRIs each month on all this stuff. These are some of the findings on MRIs, but it's a silent area. You can't touch it with your hand. This is the cauda equina down here. All these pathologies of, you know, how many people have annular tears and disc bulges and herniated nucleus pulposus, but they can irritate a sacral spinal nerve root because it comes in from S234. You've got to get up to the spine somehow, and it passes through all of that information in the lumbar area. But our nerve block, instead of the clitoris or the labia for the region 3, is we do what's called transforaminal epidural spinal injection. So we have a pain specialist stick a needle at the site of their MRI pathology and inject lidocaine. Okay, and if their symptoms go away, bango, we know what the cause of their issues are. So this is a huge stuff that we do, and it's sort of very exciting. I just want to, before we get too far into all this crazy stuff, I just want to show you this one thing here. I think it's important for everybody to know this. So this is a little technical for anyone's following this. Don't get dismayed and don't give up. It's not that difficult. The pudendal nerve, we've all been talking about the pudendal nerve. That's S234, and you can see the yellow things as S234. That's bladder, that's vagina, that's clitoris, that's labia, that's penis, all that stuff. But then also in sacral is sciatic, and that's something that the spine surgeons know because they operate on radiculopathy, like called sciatica. But the sciatic nerve is involved in S234. So we have diagnostic testing to figure all this out, that all of this sciatic and pudendal nerve ends up in the paracentral lobule. And if you have a sacral spinal nerve root coming in and you have an L4-5 annular tear, and it's causing irritation of that nerve root, the sacral spinal nerve root, that picks up in the paracentral lobule as intense pelvic pain. It's not even coming from the pelvis.
Right. Yeah.
So this is the cool stuff. Now April was part of this thing. We have this consensed expert group that put all of this together, how to diagnose and treat these chronic dysesthesia situations. So this is a sort of an outcome of all of that. And it's fundamentally changed how I think of this stuff. And, it's not that difficult to explain it to patients because they're all complicated. As Jocelyn said, they've all seen 400 people, and they're so ready for a new view that here is an example of the new view.
Yeah. You know, for the patients that come in, for example, with testicular pain, scrotal pain, penile pain, a lot of what we found as therapists is we rarely, first of all, they're very hesitant to let anybody go into their rectum to assess pelvic floor internally. I don't like to do that on the first visit for a lot of reasons, depending on how many people they've seen, and maybe they've had a manometry recently and they're not, they're a little bit hesitant to undress in the clinic. So we tend to go up the chain, especially for the lumbar nerve roots as well, because of how those dive into the groin, the scrotal area, the inguinal canal, the inguinal ring, and that can contribute to a lot of their symptoms as well, but it's nowhere near the pelvic floor, right? So that's another pearl that we've seen with our male patients.
I've seen a ton of penile dysesthesias. I mean, I have a litany of patients with penile dysesthesia, and we have the exact sort of the highway sort of story. Let's get into the highway story. So if someone comes in with a penile dysesthesia, okay, we'll say, okay, I'm doing a penile block on your penis. Okay, I'm going to stick some lidocaine at the base of your penis, block out the dorsal nerve, and you tell me if your dysesthesia goes away. So for a percentage of people it does, and for a percentage of people it doesn't. And by the way, you know what we're doing? It's really interesting. And this, I have to give credit to Jandra Mueller. I don't know if you know Jandra, but she's a PT in North County. She came to me with the patient. She said, I want you to inject 5% dextrose into perineural regions of this area. And I said, I've never done this. I've never heard of this. Why do you want me to do this? And I started reading of it, and it's sort of interesting. So we're now doing perineural injections of 5% dextrose. Jocelyn, add that to your complement of things to do. It's completely innocuous. 5% dextrose there's no side effects to this at all. But it changes the milieu of the nerve, so it can't fire. The calcium, the sodium, the potassium, they don't come out of the axon. You basically stop that. And repeated 5% dextrose injections actually relieve the dysesthesia. And I've never been so impressed in my life on a non-issue in terms of side effects. There's no Kenalog issues. There's no of the bad things that can happen. Anyways, if a patient has a dysesthesia, they get their penis caught in a zipper. They wrap things around their penis during masturbation. I mean, they do jelqing. There's a lot of weird reasons for all these things happening. We just numb it. If the pain goes away, we'll do a lot of 5% dextrose in the various places where they talk about it. Actually, you know what's an interesting genital dysesthesia is premature ejaculation. We're finding that premature ejaculation, these poor guys ejaculate within 30 seconds, 40 seconds. They have a dysesthesia of their shaft of the penis. They have a genuine region of hypersensitivity. And if you numb with BLT, that hypersensitivity, they don't have PE anymore, which for them is a life-changing event. Anyways, pain in the penis could also be from the pelvis perineum. We have a litany of people whose genital, penile, and clitoral dysesthesias are from the cauda equina. We've published on a bunch of these cases. We're publishing a series of 21 people who have had cauda equina surgery with great success on their pelvic stuff. So anyways, it's a new world to allow you to sort of explain to people and deal with the complication issues. Anyway.
When you mentioned the cauda equina surgeries, what technically is happening to those structures during the operation?
So the guy who does them in our office, he does them through a 7mm trocar. So he'll put the people on their stomach. He puts a needle as if he's doing a transforaminal epidural spinal injection. So you put the needle, you pass through the various natural holes in the system called foramina. And transforaminally, you put a needle and get into the epidural space. I mean, if you're in labor, Jocelyn talked about labor, the epidural anesthetic is done in the epidural space, okay? So, and needles pass from the outside world into the epidural space. So you know you can do that. So with the needle in place, he takes a larger trocar that then passes along and is directed by the needle into the epidural space and does the surgery through the little trocar. So there's no incision, there's no bone injury, there's no muscle injury. It's called minimally invasive endoscopic spine surgery. And it's all outpatient. Can you imagine? You operate on someone's spine at multiple levels and you never go to the hospital because you put a Band-Aid at the end. It's crazy.
Yeah. Could you speak a little bit on prostatitis? I think that's pretty much the blanket pelvic male condition that we see. And we know most of the time it may or may not be an actual issue with the prostate. And how
to me, I'm sorry to interrupt. To me, when Jocelyn talked about IC, for me as a urologist, IC is outside of the bladder versus inside of the bladder 80% of the time. And I'm going to tell you, the male IC is basically this weird term called prostatitis.
Right.
We see so many men with perineal discomfort. So perineal discomfort can happen at the perineum, can happen in the pudendal nerve area, can actually happen very commonly in the cauda equina. We see a lot of this, or in the spinal cord or the brain. So it's another form of pain that has a name like interstitial situs prostatitis. It's derived from an organ, but it's really outside of that organ the vast majority of time.
Yeah.
I just want to say one thing about IC because it's a passion of mine. We have a thing called vulvoscopy for women. When they get an exam by us, they get to see everything. They see their clitoris, their labia, the vagina. It's a big plasma TV. We have a screen. They become empowered with their anatomy. And so they get to see. So they have an IC situation. but when we examine them on vulvoscopy, when we look at their vestibule, so this sort of embryonic tissue called ectoderm, which is sort of between, or endoderm, sorry, between the ectoderm and mesoderm. It's the entrance to the vagina. It has a lateral border of Hart's line, a medial border of the hymen. If you touch those regions that are next to the urethra, so 1 and 11 o'clock, and they jump, okay, what we'll do is I'll numb the 1 and 11 o'clock with BLT, and I'll have them urinate. And guess what? The vast majority of them don't have their condition anymore. That their IC really is a vestibulodynia situation. It's really common. And it's just not appreciated because the vestibule is just not, Jocelyn said something that women aren't appreciated, or something about women aren't appreciated. B, the examination of women is completely not appreciated, and it should definitely become more appreciated.
Yeah. Are there any other common areas or drivers of pain that people think are locally driven versus up the chain that you see in your practice with men? So like
I mean, yeah, I mean, you believe the symptom you have is where the location of the pathology is, but upstream pathology is extremely common. You get the perception that it's your clitoris, your labia, your vagina, your bladder, or whatever, but it's not necessarily so. I mean, the best example of this, everybody knows about the condition sciatica. You know, you sort of have pain down your leg, pain in your foot, pain in the posterior calf, all that stuff. But you know what? There's no problem with your leg. You don't have any problem with your posterior calf or your foot. It's all referred by a radiculopathy of a sacrospinal nerve root. It's at L4, L5 from a tear, or L5S1 or something like that. So guess what pelvic pain is? It's pelvic pain sciatica. I mean, that's what it is. It's just a referral in that direction versus down the leg direction.
Mm-hmm. And are you finding you're doing very similar treatments for these issues that we talked about earlier, the nerve blocks, you mentioned the dextrose injections, the surgeries?
Oh, that's a newbie, the dextrose injection. We're just learning that. It's amazingly successful. It's scarily successful. We also have a shockwave device. We also do the CO2 fraction laser. I mean, we have all these toys. We have this Cella chair. So I think that for me, the treatment is the next step. For me, the primary issue is the diagnosis. Mm-hmm. If I can get a good handle on where the stupid thing is coming from, that has been made everybody crazy, I have a better way to manage them, is the way I think of it, at least. We're not always successful, by the way.
Do you have any wisdom on, just because it came up at the clinic this week, retracting testicles and pain in that area? Is that something you commonly see, and where do you tend to diagnose and evaluate for those types of symptoms?
Well, there's a muscle that retracts the testicle, and it's sympathetically innervated. And I guess if there's pain, it's going to, I mean, it's a protection thing so that the testicle is out of the way in a sympathetic situation. But no, I don't really have, I mean, testicular pain is yet another version of all of this. We can do a nerve block in the cord to see if the testicle is really the problem or it's referring from somewhere else.
Yeah. Any other lesser known conditions?
Arousal stuff. I mean, that's a huge issue. I mean, I don't know. It's really embarrassing, humiliating, and people find it easier to talk of pain versus they're saying, my clitoris feels like I'm on the verge of orgasm 24 hours a day, 7 days a week, and I won't tell anybody about it because I cannot believe how humiliating this is. I'm a certain religion. I'm not supposed to be doing this, and all of a sudden I'm masturbating every 4 seconds because I can't get rid of this distressing issue. So arousal is yet another dysesthesia. We have people who have this unbelievable itch in their genitals and buttocks and thighs, and they scratch it and it doesn't go away, and everybody looks for dermatologic conditions. They put steroids on and all this stuff. And guess what? It's an annular tear we just had this woman. She was a runner. She had an annular tear, and her itching went away when we fixed her annular tear. It had nothing to do with the usual stuff. Anyway.
The usual suspect, right?
You're getting close to your limit, and I'm stealing time. I'm sorry.
No, you're okay.
I get too carried away with this stuff.
Almost right on time. I think we have like 3 minutes on my timer at least. But I just want to reiterate one thing that you said, which is pain. with the blocks, and it's almost like you gave yourself a little bit of the window with the nerve blocks to pursue other treatments. But it's a warning sign when you talked about the retracting testicle. Not all pain is bad. I think a lot of people tend to, because it's persistent and it's debilitating and it affects quality of life, a lot of times pain is a negative experience for a lot of people. But I always tell people, our patients specifically, pain is an experience, and it's a Venn diagram with suffering. So you can have a paper cut, and that hurts very, very much, ironically more so than a lot of others things that are painful, but it's a paper cut. But the suffering from that, oh, I can't use my thumb, I have to adjust, I have to work around it, that can cause a lot of stress for people. But for the most part, we talk a lot about how pain is a naturally occurring warning sign for you to change something or to pay attention to something in your body. And a lot of, I think what we talked about is just connecting people, helping people connect the dots, if you will, right? Where it is, where you think it is, it probably isn't. And the pelvis is the home of a lot of different tissues. So I think we covered a lot of great stuff. So is there any other clinical pearl that popped up into your head, or patient or experience recently that you'd like to throw out there before we end? Otherwise we can.
There are millions and millions of people with pelvic pain. There's actually, I know I was a lecturer at a society called the Society of Pelvic Research. I don't know if you know this society. Never even heard of them, but there's a freaking goddamn society on pelvic research. So we need more doctors interested in this, to be quite honest. Urogynes are a fabulous opportunity. I'm a little disappointed in my urology community because it's not where they want to be. They like doing other things, but we need more doctors doing this stuff, and more. We need to become more organized in our thinking, our presentation of all this.
Yeah. Dr. Goldstein, I would love to ask something really quickly. Of the 111 patients that have had the surgery recently, how many of those had Tarlov cysts versus ones who had annular tears? And just, I think the finding of the driver being something very different than what we have been, typically treating for decades is a fabulous idea. But then just thinking about that, if you did MRIs of the general population, something like 39% of them have disc bulges or tears. So how are you differentiating? Is that truly the driver, or is that just something that has been there and is truly not a problem?
Jenny, you're like brilliant. You realize how brilliant you are. It's amazing. That's a huge dilemma. I didn't realize that if I just walked outside and said, here's $100, come in, no symptoms needed. In fact, no symptoms wanted. If you did an MRI of your lumbar area, 30+% would have pathology there. So we've identified strategies. They have to have a history. They have to have symptoms. They have to have, we do neurologic testing, a ton of neurologic testing. They have to have impaired integrity of the neurologic examination. They'd have to have on an injection into that region in L5S1, for example, that their symptoms go away. I mean, we have to document that they have something that is medical versus just have something that is on an MRI.
Excellent. Thank you. And then there was a question for Dr. Craig in the chat, which was, how does estradiol compare to oral and vaginal estrogen transmission? The estradiol, I did ask her a follow-up question. She is currently using estradiol by patch, but has a history 3 years ago of uterine cancer.
So, vaginal estrogen is not absorbed in the same manner into your bloodstream. There is some absorption, but to date, knock on wood, there's no clinical studies that show that vaginal estrogen causes cancer. Correct me if I'm wrong, Irwin.
Oh, you're 100% correct.
So,
despite the warning on the stupid label.
But I tell patients, I tell them up front, you're going to open this package and it's going to say, warning, this can cause cancer. A cup of coffee can burn you if you hold it in your lap and drive, right? But it's not going to burn you when it's on a table. Okay, so vaginal estrogen, if taken orally, has some risk factors, but vaginal estrogen to date has not been linked to any cancer. That said, I always get, if somebody has a history of cancer, for their peace of mind and for mine to make sure I'm not missing something, I ask them, look, if you're still being followed by an oncologist, let's have them weigh in and see if they're okay. And uniformly, especially patients that are long out from a diagnosis, maybe there wasn't any lymph node involvement, vaginal estrogen is safe. Now, what happens is, what are you using it for? So vaginal estrogen is usually not enough to help with vasomotor symptoms. Vice versa, topical or oral estrogen may not be enough to help with your vulvovaginal symptoms, right? When it gets into more of hormonal issues and vasomotor symptoms, I kind of hear a dial tone because I'm more interested in pelvic floor issues, but it's relatively safe and often more safe than patients would imagine. Yeah.
Thank you.
Mm-hmm.
If there's any other questions, I think we're good.
Yeah, I think that was great. That I don't see any other questions in the chat. I want to thank all three of you for your sharing, your generous sharing of knowledge. I really appreciate that. Next month, we are going to be talking a bit about persistent pelvic pain science. So looking at the changes that happen in the brain with persistent pain and the type of conservative treatments that we as physical therapists integrate into our practices for treatment of those types of pain conditions. So both our Facebook Live Q&As, the first Wednesday and the last Wednesday of the month, will be on that topic. And then we will be having an interview mid-month as well. So watch out for our posts on that. You will get notified either on social media if you follow us that way, or by email if you've been a previous patient, and you can sign up for that. All right, we will see you guys soon.
Thank you very much, everybody.
Bye,
Appreciate it.
everyone.
It's nice to see you, Jenny. I don't get to see you because of COVID, but God bless.
Take care.
Thank you. Bye-bye.
Bye-bye.
All right, I stopped the recording. And I stopped. Oh, they both just popped off. I was going to say goodbye to them a little more formally than that.
Right.
While I was trying to like stop all the stuff.
It still says recording, but I think it might just be my screen. I'm not sure.
There we go.
Oh, the live thing went off, but then the recording is still going.
I thought I hit it.